Tuesday tips. Thank you so much for joining every Tuesday to discuss different topics of plastic surgery, and obviously I get to answer your questions. Today we're going to talk about a topic that last week I got some questions and people wanted to know a little bit more about, and that is capsular contracture. So what is that? Capsular contracture is a possible risk after putting an implant, after breast augmentation, breast lift with implants. Any procedure that involves an implant to the breast has a risk of capsular contracture. How much? There are different research and documentation that describe different rates of capsular contracture depending on the procedure. But roughly, elective cosmetic procedures is around 10%. So 1 in every 10 patients may develop capsular contracture. What are the risk factors, or what is it? So there is a process that involves an inflammatory process that the body does around any foreign body. So that happens if you get a knee replacement, if you get a rod on your arm because of a fracture, anything foreign, your body's gonna form a capsule around it. That's our immune system attacking and kind of, forming a barrier to that foreign thing from ours. So every breast implant has a capsule, but when this capsule becomes hard or symptomatic, that's when we call it capsular contracture. So every single person has a capsule, and that's okay. And actually, we want a capsule to form because that's going to keep the implant in place. When the capsule forms too loose, that's when you may notice that if you're laying down, the implants go to the side or they go to the armpit area. So a capsule is good, but we want to keep the capsule healthy and not hard, painful, symptomatic. So what are the risk factors? How do I know if I'm going to develop a capsular contracture? Unfortunately, we don't know for sure. I can't say you are going to develop it and you're not, because if that was the case, beautiful. I'll just tell you don't get implants because you're going to develop capsular contracture. Fortunately, we don't. We can just manage the risks. What are the risks? The type of incision approach, okay? So incisions that are for example, in the axilla, in the areola, those incisions are higher risk of capsular contracture. That is why my breast augmentations, my preferred incision is to put it in the fold, or IMF incision, away from the breast ducts which carry bacteria. So anything that increases bacteria increases risk of capsular contracture. So incision approach. Number 2, infection risk. So that's why I put you on antibiotics. During the surgery, after the surgery, I put antibiotics and betadine or iodine to flush and clean the implants before putting it in. And I use a non-touch technique. What does that mean? I don't touch the implant from where it comes to your body. It comes in an envelope that it's sterile, and that I pass it directly in what's called a funnel, a Keller funnel, which is like a plastic bag. Put it directly there, and with the funnel, I literally push it inside of that cavity that I formed. So things that minimize touching in bacteria, all of that decreases risk of capsular contracture. And unfortunately, there is some genetic predispositions, right? So if you have a history of keloids, hypertrophic scarring, that means that your body is more prone to develop thick scars, and you have a higher risk of developing capsular contracture. So what are the grading systems? So there's a classification called the Baker classification for capsules. It's 4 numbers. The number 1 is basically a normal capsule, the one that I described everybody has, okay? So grade 1 is a soft, non-deformed capsule. We're good there. Grade 2 is that capsule, now it's hard, but visually you don't notice any asymmetry or difference. So you're standing in front of the mirror, they look symmetric and fine, but when you touch it, it feels a little hard, okay? Number 3, or grade 3, is hard and you're starting to notice some deformity. So it usually is that one is a little higher, starts to get contracture, so you notice that one implant is a little bit higher than the other. And grade 4 is hard, deformed, and painful. That's when that capsule is so hard, sometimes it turns into a rock. Very hard, painful, and at that point, then we need to do something about it, right? So what are the treatments? We talked about the risk factors, who's at risk of developing it, talked about the grading system or diagnosis. So what do if we start to notice this? Usually you won't start to notice for 3 to 6 months after the surgery. This is not something that develops right away after the surgery, okay? Other things that I didn't mention or risk factors are post-op complications such as seroma, hematoma, infections. So if you developed any of these in the early post-op period, that increases the inflammatory response. Again, right? Inflammation, bacteria, that's what causes that scar to become thicker, okay? So that is why, for example, if you develop a hematoma in the early post-op, I'm gonna take you back to the operating room, drain that hematoma, and clean everything up, because if we don't take that blood out in a few months down the drain, we're end up with a capsular contracture. So it's better to, correct the problem right away and don't wait for the problem to get bigger and more complex. Okay, so what are the treatment options? If we're starting with a milder version of a capsular contracture, so 2 to 3, it's hard, but it's either not deformed or very mildly deformed, then we can start conservative treatment of the capsular contracture, which means massages and LRAs, or leukotriene receptor antagonists. Basically, montelukast or Singular, the medication that we use for allergies. That medication decreases inflammation. That's why it's used for allergies. So it's been shown to improve capsular contracture progression, and actually in 30% of patients, it lowers the grading. So if you started with a 2, goes to a 1. If you started with a 3, goes to a 2, okay? So what is the treatment? The Singular is 10 milligrams at least for 3 months. So it's not that you're gonna start the pill, the next day your breast's gonna be soft, okay? Takes time, because it's that inflammatory response that we are kind of halting, and the massages is kind of breaking that scar. So it's not only taking the pill, you have to do the massage. What's the massage? It's basically moving the implant side to side, up and down, and in angles for at least 5 to 10 minutes, 2 to 3 times a day. Kind of breaking that scar, softening that up, with the addition of the Singular or montelukast. And that is for at least 3 months and up to 6 months, okay? So I've been taking this pill for a month and it's still the same. You have to give it time, okay? And the goal, like I mentioned, is decreasing for at least 1 grading system your capsular contracture, okay? The other, if we are in a more severe capsular contracture grading, either 3 or 4, which is painful, deformed, then in those cases, it's up to the patient to where we go. If we're starting in a 4, if you do conservative treatment, it's pretty expected that's gonna go to a 3, which means it's still gonna be hard, it's still gonna be a little deformed. If you're not, it may improve, but you're still not gonna go to a 1 or 2, okay, with just conservative treatment. And if you're a 3, then you may go to a 2, and you may be okay with that, okay? So I always have the discussion with my patients that develop capsular contracture, that the decision is up to you. This is not emergency surgery needed. It's more how much this bothers you and how much deformity you have. If we're in a 3 to 4 that it's bothersome, or you try to 6 months of treatment and you have seen no difference, the option is surgery, okay? What is the surgery? The best approach is to remove that capsule completely, exchange the implant to a new one, and change the plane where the implant is. What does that mean? If your implant was under the gland or under the breast tissue, we put it under the muscle. And I forgot to mention the risk factors. One of them is subglandular or under the breast implant placement, okay? If we put it under the muscle, risk of capsular contracture is lower. So one of the treatment options is remove the capsule, put it under the muscle, and in cases of continued recurrence, then we may need to add what's called an ADM or a mesh, okay? Acellular dermal matrix, which is basically a mesh synthesized, or it's taken from cadavers, but it's taken all the cells out, and basically it's just a matrix of tissue that kind of wraps the implant and kind of creates that support to decrease the need for the body to create more inflammation and create a new capsule, okay? I try to leave ADMs for second capsular contracture surgeries, which means you develop capsular contracture within the original surgery, you had capsular contracture again, then I think you would be a candidate to add an ADM or a mesh, okay? If you have capsular contracture the first time and we're doing the surgery, it is something to consider to add the LAR or Montelukast single layer as prophylaxis for 3 months after the surgery to try to prevent the recurrence of capsular contracture again, okay? In terms of prevention, since I mentioned this, it is not approved for everyone to be in single layer. Not worth it. It's been studied, but it's not worth it. And the other thing is massages. I do recommend you can massage it, but it's important to massage it after the first 2 to 3 weeks. Okay, if you start massaging the breast too soon, then it can increase the risk of bleeding or making that capsule too big and implant too mobile. Okay, I'll take some questions now.
What does your BMI have to be for a breast reduction and lift?
So my max BMI is 33.5, okay? That is the max BMI for all procedures, including breast reduction and breast lift. I do recommend everyone to get or try to get to at least a BMI of 30. The reason for that is that 30 decreases the risk of complications such as wound healing and infection, and also anesthesia risks such as lung, cardiac, or blood clot risks, okay?
Can I get an extended tummy tuck, lipo 360, and lipo inner thighs in the same procedure?
Okay, so I do not recommend adding all those procedures in one. Two main reasons what I personally don't do it is safety and recovery, okay? So safety reasons is the most important one is when we're doing the tummy tuck, the center of the abdomen is lifted so I can do the muscle repair, which means that skin is living from the blood supply that the vessels bring down. If I do liposuction in that tissue and thin that up, you can end up with necrosis of the skin because the blood supply is being damaged with the cannula of the liposuction. That's why with the tummy tuck, I only do liposuction to the flanks, not in the center of the belly where I'm lifting it for the muscle repair, okay? The other consideration is because I operate in an office-based facility in the state of Florida, and there's a limit because of safety reasons of the amount of liposuction I can remove when I'm combining it with open procedures, okay? And that is 1 liter max. It's not gonna be enough for a 360 to give you a good result, so it's better. I recommend doing the tummy tuck first, waiting 3 to 6 months, and then we can do the lipo 360 and the inner thigh lipo.
When can you start laying on your breast after surgery?
At least 3 months, okay? Especially if you have an implant. If you don't have an implant, 6 weeks is fine. But if you do have an implant, remember I mentioned that capsule, I want the capsule to form in the implant pretty snug. So when you're laying in the future, the implants don't go to the sides when that capsule is too big. If you start sleeping in them, that's gonna stretch that capsule up, and that's gonna make the capsule very big and the implant mobile. So it's better to try to sleep in your bag and avoid sleeping in them for 3 months after the surgery.
How many days before I can dry after a tummy tuck? How about walking by myself?
That's a very good question. Rule of thumb, driving after surgery, I say 2 weeks. The safety reasons is I want you pain control wise good, that you can maneuver if you need to, and if you end up in an accident, you can, react accordingly. And the other one, if you need to be off narcotics, okay? Depending on the surgery, with the tummy tuck especially, you're gonna be hunched over, so you can't really drive safely like that. So by 2 weeks, you can stand a little bit more straight and drive more safely.
And how about walking by myself?
Walking by yourself the day of surgery, it's fine, okay? I want you off and walking the day of surgery. You need someone with you to assist you in case you get dizzy, but you can walk by yourself day of surgery.
How much lipo can you do with a tummy tuck?
Lipo to the flanks, waist area, okay? Not the center because of the blood supply issue that I explained.
What's the best pain management post tummy tuck for bariatric patients? The Exparel?
So combination. So Exparel is extremely good. I do recommend it. The majority of my patients that add Exparel to their tummy tuck surgery need the narcotics for the first 24 hours or not at all. So I do recommend adding Exparel. For those of you guys that don't know, Exparel is a local anesthetic that lasts up to 72 hours, and I inject it in the muscle for the muscle repair part and also the incision. So very good pain control in those first 72 hours post-surgery, which usually are the most uncomfortable and painful. But the best treatment or the best pain management after tummy tuck or any procedure is actually a combination of things, okay? So one is the narcotics, so if we do Exparel, then you're gonna go home with a narcotic. You can intercalate it with Tylenol. And then at 48 hours post-op, you can start NSAIDs or ibuprofen Motrin to add into that pain control.
Can you combine tummy tuck, thigh lift, and breast reduction?
So tummy tuck and breast reduction, yes, that's what we call the mommy makeover. So those two procedures are okay to be combined. The thigh lift, I like to do it alone. The reason why is the incisions of the thigh lift tend to be the ones that give a little bit more problem with healing, okay? Gravity, swelling near the genitals, so all of those things increase the risk of wound openings, infection. So when I do that surgery, I want to focus on that area and not other surgeries to kind of interfere with the recovery.
Tengo 46 años. ¿Tengo mucha edad para hacerme un mommy makeover?
Claro que no, 46, jovencita, una nena. Así que, claro que no. Mi límite para mommy makeover son 55. Y si tienes más de 55 hasta los 60, podemos hacer either la barriga o los senos no combinados. Pero si hasta los 55 años, si estás saludable, las cositas que hay que verificar es tu BMI o índice de masa corporal, si tienes alguna condición médica como presión alta, diabetes, que todas estén controladas.
I had a lift with implants. If I want to change for a smaller size, does the lift need to be redone?
If you want to change for a smaller,
Yes.
for a smaller size, usually yes. It depends on how smaller you want to go. But usually when we change to a smaller size, then you have loose skin that we have to retighten up.
Okay, another one about breast.
Okay.
How long do you have to wait to do an implant change?
At least 3 months, okay? So I want that capsule to be formed because I use that capsule to either retighten it, support the implant. So it's important to at least 3 months, sometimes up to 6 months.
Okay, and the last one, what are the risks of the anesthesia?
Okay, so broad question in terms of we can divide the risk of anesthesia in different things. The most common side effects or results of anesthesia is actually nausea, vomiting. That's the most common. Dizziness, okay, and feeling groggy for those 24 hours after the general anesthesia. Those three are the most common. I send you with Sofran, which is a very strong anti-nausea medication, just in case you develop those side effects, you're good to go, okay? Other risks are a little bit more, are higher in complications, like cardiac risks, pulmonary risks. Those are very low if you get your medical clearance, EKG is good, chest x-ray is good, and all the other comorbidities are controlled. Very, very slim to none. Other risks of anesthesia are related to the tube. So very, very common, you may have sore throat, dry mouth, and all of those usually last for a couple of days after and then go away. Blood clot risk with general anesthesia may be up to 2 weeks after surgery. That's why the protocols regarding walking, compression socks, compression devices, I ask you to do it for 2 weeks, okay? That's it. Okay, you guys, thank you so much. I hope this helped answer some of the questions of capsular contracture. And if you did develop a capsular contracture, what are the options of treatment before jumping into surgery? If you have any questions, please DM DM me or write me in the comments. And if you have any recommendations of the next topic, please also DM me or put it in the comments. And I'll see you guys next Tuesday on Tuesday Tips. Have a beautiful week. Take care.